All right. I want to welcome everybody to the oral presentations of our resident research day. We're going to start with the clinical papers. And again, just to make a couple of thank yous to Dr. Arden Morris and to Dr. Olivia Martinez, our vice chairs for research, and the Research Council for their tremendous effort in selecting the papers for the presentation today and really putting the program together. So thank you very much for all your hard work and making this such a great day for us. Our two moderators for the clinical papers are Dr. Elsie Ross from the Division of Vascular Surgery and Dr. Cliff Schechter from the Division of Plastics and Reconstructive Surgery. So thank you for serving as our moderators for this session, and I'll turn it over to you.
All right. Everyone can hear me here? Great. We're going to start off with Jeff Choi speaking about tackling the bedside artificial intelligence barrier, natural language processing to extract injury ICD-10 diagnosis codes real time from electronic medical records. We'll have 8 minutes per presentation and then 4 minutes for questions after. Thank you.
All right. Is my mic okay? Mic check? Okay, great. All right, well, good afternoon, everyone. I'm Jeff Choi, general surgery resident and bioinformatics graduate student. Thank you all so much for joining today. All right, so over the next few minutes, I'll start by outlining a problem, review some concepts that are needed to understand our solution to the problem, and end with some thoughts on building useful clinical prediction tools. So let's talk about ICD codes. Are ubiquitous. This language that defines clinical diseases, it's widely used for billing and for research. And more recently, there's a lot of interest in building clinical prediction tools. And a lot of these tools use ICD codes as input variables. So let's look at how ICD codes are extracted today. As providers, throughout a patient's hospitalization, we write a note or two or a couple more. And after a patient leaves the hospital, these notes are thoroughly scanned by our registrars who assign and enter ICD codes into databases. And as researchers, we access ICD codes really downstream here. So this process is very labor intensive. ICD codes are often not assigned until more than a month after patients leave the hospital. So today, despite surging interest in clinical prediction tools, today, their necessary input variables, ICD codes, are not available real time. So it's a big problem that we have right now. So our solution to this problem lies at the intersection of deep learning and natural language processing. So what's deep learning? We're all familiar with general regression architecture, where a series of inputs directly map to an output. In deep learning, there's just a bunch of hidden layers that are in between, and these hidden layers facilitate mapping more complex relationships, thereby facilitating often making more accurate predictions. And natural language processing, it's a process that allows machines to understand languages as humans do. Google Translate is an example. So let's discuss trauma ICD BERT. Our study aim was to make ICD-10 codes available real time. We aim to build a natural language processing model that can automatically extract ICD codes from the electronic medical record. And this model is called Trauma ICD BERT. Over the next minute, I'll provide a very bird's eye overview of our methods. If you're interested in the details, you can scan that QR code in the corner, and that will link you to our technical paper. So our study population comprised electronic medical records of approximately 3,500 patients who were admitted to our trauma service. And when we were designing our study, we really started by thinking about how the end user would use our ICD code extraction algorithm. To make codes available real time, the model input has to be notes that succinctly summarize the injuries that the patients have, and notes that are ideally written within 24 hours of a patient coming into the hospital. So what kind of notes is that? Trauma tertiary survey notes. So trauma ICD BERT was trained using trauma tertiary survey notes as the input variable, and it would output the list of predicted ICD codes as an example here. So let's look at how our model performed. We compared our model against the performance of an existing industry standard from Amazon. And the takeaway from this slide, lots of numbers here, is that trauma ICD-BERT outperformed Amazon's model across nearly all metrics. But now let's look at these numbers in depth a little bit. Let's start with area under the curve, ARC. So this is probably one of the most commonly reported performance metrics in prediction tool literature today, but we have to be very careful when we interpret ARC. So we have the gestalt that 1 is good, 0.5 is bad, but what does the number actually mean? It's really important to understand that a higher AUC doesn't necessarily mean that the prediction tool is better. And that's because most clinical prediction tasks involve what's called imbalanced data sets. There are few positive cases that we care about, and comparatively, lots of negatives that we care less about. And ARC considers false positives and false negatives to be the same, which is an inappropriate assumption for most clinical prediction tasks. So if we step back and think about what prediction tasks tools are trying to do, we'll find that recall or sensitivity is a more important metric. So let's take an example of a patient who suffered only one injury, rib fractures. And let's say that one model outputted 3 predicted outcomes. So 1 true positive at the top and 2 false positives below. And imagine a second model outputted just one wrong prediction. So it'll be 1 false positive and a false negative. And if we think about how the end user would interpret these outputs, to a certain extent, it's more practical to ignore false positives than it is to look up a code for an ICD code that was never predicted in the first place. So for these scenarios where mitigating false negatives is important, recall or sensitivity is an important metric to evaluate. So this table shows our model's recall performance for all ICD codes, the top 50 and the top 10 most frequent ICD codes in the data set. And the takeaway is that the more data our algorithm was trained on, the better was the performance. And for the sake of time, if you're interested later, I'd be happy to chat about exactly what the @5 means later on. So to start closing, there is a lot of interest in clinical prediction tools today. But unfortunately, recent literature shows that a lot of these tools don't actually get implemented at the bedside. And even if they do, they don't really improve any meaningful outcomes. So I think to build useful prediction tools, we really have to think about the end user. And the analogy I like to make is a salt flats racing car on the left and a Tesla on the right. The salt flats racing car is extremely fast, but isn't really practical for everyday use. As opposed to the Tesla, not as fast, but it was designed specifically for everyday users, and we see them everywhere, maybe just in Palo Alto. So it's not just about achieving AUROC. We really have to think critically about how to design, evaluate, and implement prediction tools that we're working on. And one way that our trauma group has tried to bring clinical tools to the bedside is through mobile applications. And along the same vein, this is the trauma ICD-BERT user interface, a beta version that we've set up. So essentially, surgeons can paste or type in free text describing patient injuries, and the interface will automatically output the predicted list of ICD codes. And these predicted outcomes can be exported for use for future validation research or be integrated within existing prediction tools. So in essence, instead of accessing ICD codes 40 days after patients leave the hospital, with trauma ICD-BERT, we're trying to make them available directly at the bedside within 24 hours of admission. So I hope this talk has generated some excitement about bringing clinical prediction tools to the bedside. And we can't wait to release trauma ICD-BERT to the world in the coming months. I'd like to thank our project team, our trauma team, and along with Dr. David Spain, Dr. Joe Forster, and Lakshika Tenakun, who've been instrumental in teaching me everything I've learned over the last 3 years of research time. And thank you for your attention.
Thank you very much, Dr. Choi. We'll open it up to the field for questions. We have about 4 minutes. Please just walk up to the mic. Just while we're waiting for anybody to come up, one question I had, Did you find there was a particular subset of notes where your model performed better, i.e. notes written by certain people? Could you kind of analyze that to see, where it's recognizing better and where it's failing?
Yeah, great question. So we did what's called error analysis to look at where our model really does not perform well versus better. And like I suggested, notes, our model performed best in cases where the ICD codes were seen the most. So for example, rib fractures, essentially it got almost every single rib fracture case because it was trained hundreds of times. But more rare injuries like aortic, like traumatic aortic injuries, performance was low for those specific injuries. I think that's because of the limitations of we didn't have enough training samples for the database.
I want to congratulate you. This is really fascinating work. I think a lot of the work we're doing will head in this direction. I have a very naive question. I know you're going after ICD-10 codes. Why not just after free text? And you probably have looked at that.
Sure. So I only showed the ICD codes here, but it actually does predict the free text that's associated with the ICD-10 code. And the reason we're working with the ICD-10 code language is that a lot of at least in trauma, the prediction tool literature, their input variables for research are ICD-10 codes. So to provide the input variables for these downstream tasks, we wanted the output to be ICD-10 codes to really integrate it with the existing tools. So that's why we kind of titled the talk Breaking the AI Implementation Barrier, because I think right now the implementation barrier is that these codes are not available real time. So we want to make specifically these ICD codes available real time as inputs.
You might be able to show that if you, and I understand that the data up to now has really leaned on the ICD-10 codes, but as we know, ICD-9 and ICD-10 and CPT codes are also somewhat limited and really meant for reimbursement purposes, especially CPT codes. And so I wonder if there's a future where actually this will be kept out of the equation altogether.
That'd be very interesting, because if there's a way to directly capture information without using a relatively foreign language, that would be the dream.
Yeah, I think just to build on that question, I mean, there are data that are immediately available, vital signs, laboratory data, and things like that. So an ICD-10 code isn't very granular in terms of, rib fracture is a rib fracture. And then how would, thinking of something that would be updated continuously with vital signs, pulse ox, oxygen requirements, and things like that to differentiate that patient who's got a very stable, going to get discharged, and that patient who may be deteriorating with some underlying pulmonary injury or something. So have you thought about how you're going to make this even more robust, and maybe something that just isn't a one time, but something that's a living kind of updated model throughout the hospital course?
Great question. We actually have another algorithm that we're working on that uses, in addition to ICD-10 codes, other kind of realistically available clinical data like vital signs. And so this is kind of a part of the inputs, and we have other clinical data, and we're trying to build a prediction model to predict kind of outcomes among injured patients. So we do have another model that we're working on. That's a great question.
Hey, Jeff.
Great presentation, Doc. Oh, one more quick question.
The question. So Amazon has come up with their own algorithm, and how have they trained it differently? Do you know what their background was?
Yeah. So their algorithm, it's meant to translate all healthcare tasks. So in essence, it wasn't trained specifically to translate ICD-10 codes from text. It was meant to extract whatever output the user wants based on the input free text that it provides. So it's trained using things like PubMed databases. I'm not sure which hospital, but they were trained using other hospitals like electronic medical record system. So Amazon's system is meant to extract whatever the output is. ICD-10 code is like one of the potential outputs, but they can output lots of different outputs based on free text. So that's what their model was trained on.
And then ICD-10 codes, are those trademark or copyrighted, or what's the ownership on? Like CPT codes are owned by the AMA, I think, right? But
it's maintained by the World Health Organization, but I'm not sure in terms of the whether it's copyrighted or not. But it's maintained by the WHO.
Any other burning questions? Great job. I will leave you with this. I think one great student project is to try multiple industry algorithms. So Google also has some, and then there are others. And what would be interesting, since you guys want to publish this and make this available to people, is to compare across different algorithms what's better for certain things so that people have it as a research tool. But great job. Our next presenter is Dr. Charles Liu, who will be presenting predictive value of clinical complete response after chemoradiation for rectal cancer.
Thank you so much, everyone. My name is Charles Liu. I'm one of the fourth-year general surgery residents, and I'm really excited to share our research on understanding the predictive value of a clinical complete response after chemoradiation for rectal cancer. So currently, locally advanced rectal adenocarcinoma is treated first by giving upfront neoadjuvant chemoradiation with or without neoadjuvant systemic chemotherapy, followed by surgical resection. And the reasoning for giving radiation first before surgery is to try to shrink the tumor, irradiate the lymph node basin, potentially reduce the morbidity of the operation, and increase the chance of a complete R0 resection. And this approach is enshrined in our NCCN guidelines for the treatment of rectal cancer. But the fact that we give neoadjuvant therapy first has led to this, one of the critical questions and ongoing for many years debate in rectal cancer and rectal surgery, which is it possible to avoid surgery entirely if the neoadjuvant therapy has eliminated cancer? And to answer this question, we have to understand the relationship between two different outcomes. The first is CCR, or a clinical complete response, which means no remaining cancer detectable on clinical assessment. And the second is PCR, or pathologic complete response, which means no remaining cancer cells in the rectum. So what does the prior literature show us about the relationship between PCR and CCR? Well, in 3 different studies from 2002 to 2017 from the US and the UK, among patients who had a complete or near complete clinical response to neoadjuvant therapy, only about 15 to 25% of these patients had a pathologic complete response, which, if you think about it, is not very good for when it comes to counseling patients and making clinical decisions. But since these studies have come out, there have been a number of changes in our approach to neoadjuvant therapy. For example, currently today we use a lot more of what we call total neoadjuvant therapy, or TNT, which means giving not only chemoradiation, but all of the patient's expected systemic chemotherapy before surgery as well. And also, especially here at Stanford, we've adopted the increased use of short course radiation therapy, which is only 5 days long instead of 5 weeks, and is therefore better tolerated and more likely to be completed by patients. Furthermore, our assessment for whether the patient has had a clinical complete response also now includes more technically advanced studies like a pelvic MRI routinely, which may change the relationship between CCR and PCR. So that led us to our research question, which is, what is the association between CCR and PCR in locally advanced rectal cancer in a contemporary US patient cohort? So to answer this question, we identified all patients age 18 and older with rectal adenocarcinoma who first underwent neoadjuvant chemoradiation and then had an index proctectomy here at Stanford Hospital over the 10-year period from 2012 to 2021. We conducted a chart review identifying patients using ICD and CPT codes and identified those patients in the Stanford Research Repository, or STAR, which many people here will have used. We did conduct further chart review in EPIC if required for clarification, and our chart review was conducted by 2 general surgery residents and 4 medical students over a 3-month study period. We conducted data analysis, including descriptive statistics in Stata 16. In our analysis, whenever an MRI was done for restaging, we used the MRI restaging for determination of whether the patient had a clinical complete response. If an MRI was not done, then we used a restaging PET scan to determine CCR. And if neither an MRI nor a PET was done, we used restaging CT. We defined CCR as no residual tumor seen on imaging, and a PCR as no residual adenocarcinoma in the surgical pathology specimen, as determined by the Stanford pathologist. Our initial query identified 637 patients who had surgery for rectal cancer over the 10-year study period. We eliminated 114 patients who didn't receive any neoadjuvant therapy, 57 who were operated on for either a cancer recurrence or a non-cancer complication of a prior rectal cancer operation. 71 were eliminated because they didn't have any restaging imaging after their neoadjuvant therapy, and 35 were excluded for other reasons. In total, 360 patients met our inclusion criteria, of whom 167 had their CCR status determined by MRI, 115 by PET, and 78 by CT scan. So here are the characteristics of our patient cohort. The mean age that our patients had their proctectomy was 57.3 years. About 37% of our patients were women. 48% of our patients were white, and 52% were non-white. 57% of our patients had an LAR, or a low anterior resection of the rectum. 36% had an APR, or abdominal perineal resection of the rectum, and 5% had a pelvic exenteration. And then kind of just get into the meat of it. In our cohort, 10 years of Stanford patients, 13.6% of patients had a clinical complete response on their restaging imaging following neoadjuvant therapy, and 12.2% had a pathologic complete response on their surgical pathology specimen. So how well did those correlate? Well, this slide shows the results of our primary study analysis. So of the 44 patients who had a pathologic complete response, only 15% had a clinical complete response on their restaging imaging, meaning the sensitivity in our cohort of CCR was only 34.1%. Of the 49 patients who had a clinical complete response on restaging imaging, only 15 had a pathologic complete response, which meant the positive predictive value was also only 30%. The negative predictive value and the specificity were much higher at 91% and 89% respectively. We then did a sensitivity analysis where we only looked at patients who had MRI done for restaging following neoadjuvant therapy, but found no significant difference in our results, with a sensitivity of 30.8% and a positive predictive value of 26.7%. We did another sensitivity analysis excluding patients in the first 5 years of the study period, with the thought that there has been some evolution in our approach to both neoadjuvant therapy and surgical approaches, but found no significant changes in the results either, with a sensitivity of CCR of 29.2% and a positive predictive value of the same. So in conclusion, in our study of a 10-year cohort of Stanford patients undergoing surgery for rectal cancer, locally advanced rectal cancer, the sensitivity of a CCR for predicting a PCR was only 34.1%, and the positive predictive value was only 30.6%. So the positive predictive value that we find for CCR is about 20% higher than that reported by a widely cited study from Memorial Sloan Kettering from 2002. But our results do highlight the fact that even today, CCR should still be interpreted with caution when counseling patients due to its relatively low positive predictive value. And this further underscores the critical importance of surveillance in patients who, in discussion with their surgeon, elect to undergo non-operative management, or what we call watch and wait, after having a clinical complete response to their neoadjuvant therapy. And further research is needed to define the optimal surveillance regimen, since we don't have a single best evidence-based surveillance regimen for patients who watch and wait. I'd like to thank my mentor, Dr. Arden Morris, for her mentorship and guidance on this project, our radiology collaborator, Dr. Vipul Sheth, my co-resident Ken, and our excellent med students, Anna, Ankh, Dong, and Yvonne. Dong's here today, who did a ton of hard work on this chart review. Thank you very much.
Great job, Dr. Liu. Questions?
Yes.
So I'm not completely sure about colorectal cancer, but in some other tumors, you can measure circulating tumor DNA. And I know that there are some trials with radiation oncology where you can measure that when you have a complete response, that the circulating tumor DNA is going down. And this is also a very good predictor if you have recurrence or not. I'm not sure. Is there anything for colorectal cancer?
That's a good question. I actually learned about ctDNA like last month on the colorectal service. I had not heard of it before. I don't know if it's in routine use by our medical oncologists. I've seen it. The patient that I saw it used for recently had small bowel adenocarcinoma. We didn't collect that variable for our rectal cancer patients. I don't think it's being routinely used, certainly from reading the notes and being in colorectal surgery clinic. I don't think ctDNA is being routinely used for our patients who elect to watch and wait. But there's definitely something really interesting that is going to be a bigger part of our surveillance and our counseling to patients going forward. Yeah. Mm-hmm. Okay. Yeah, let's talk about it afterwards. Yeah. Thanks, Iris. Dr. Norton.
Charles, that was an excellent paper. Did you look at survival of the clinical complete response versus the pathologic? Was there any difference in survival?
That's a really good question. We'd like to. We have not yet looked at that. As you probably saw, our study cohort goes up to people who had surgery as recently as last year. So we haven't looked at outcomes, and we don't have long enough follow-up for many of the patients. But we certainly could, for patients in the first 5 years of our cohort, look at their 5-year survival, for example, and it's something we should do, because ultimately that's the ultimate outcome, more so than a more intermediate outcome.
Another relevant, interesting paper is there was a study in Cell just this past year where they gave interleukin-1 receptor antagonist and followed with chemoradiation, and they doubled the complete pathologic response.
Wow.
You should check that one out.
Yeah, for rectal cancer?
For rectal cancer.
Okay, I'll look that up.
One last burning question, Dr. Narayan.
Yeah.
Charles, thanks for this great paper. This is really excellent work and super pertinent to the question of who we should be doing watch and wait for. I'm curious for the folks that, especially that underwent an APR, if there was a plan to in the future, or if you had the opportunity to look at folks that went for colonoscopy after having clinical complete response on imaging, and to see if there was any association there that can help prevent them having to go to the operating room.
Yeah, no, that's a really good question. We did collect that data point. So the couple other data points we have are patients, whether patients had a restaging scope and what the results of that were, and whether they had a digital rectal exam, which often is actually not documented. We didn't include that because those variables were quite incomplete, were like high degree of missingness, and we would have had to cut down our sample size quite a bit. We do plan to go back and take a look at the subset of patients we have, like a complete, like all 5 data points, MRI, PET, CT, scope, and digital rectal exam, to see if among those patients we can look at what the findings were, although the sample size does get small.
All right, another round of applause for Dr. Liu. Thank you. Next up, we're going to have Kathryn Taylor speak about out-of-pocket spending and work loss after common surgical procedures among working-age adults.
Hello, everyone. I'm Kathryn Taylor. I'm a general surgery resident and a second-year fellow with the National Clinician Scholars Program at the University of Michigan. Thank you for the opportunity to present our work on out-of-pocket costs and missed work and short-term disability among working-age adults after common surgical procedures. Surgical patients are uniquely vulnerable to financial toxicity, which are problems caused by the cost of medical care due to high costs and limited treatment alternatives. Financial toxicity can result directly from out-of-pocket costs, including deductibles, copays, and coinsurance, as well as indirectly through missed work, disability, and other sequelae from recovery from surgery. In fact, we previously found that half of surgical patients report financial toxicity in the year after surgery. Using the National Health Interview Survey, we previously found that 1 in 3 surgical patients report general financial strain in the year after surgery, including worry about paying their monthly bills, housing costs, credit card bills, or food insecurity. And 2 in 5 reported unaffordable care, including medical debt, altering their medications due to cost, and having unmet need or delayed or deferred care due to cost. And we feel that this is really important because these components of financial toxicity can affect how a patient recovers from surgery, from having enough nutrition to support them while they're healing from their surgery, to taking the prescribed medications post-operatively at the intended dose and strength instead of skipping or altering the dose of medications due to trying to reduce the cost. Our goal with this study was to assess the economic impact of surgery on patients' out-of-pocket spending and work loss among working-age adults with employer-based insurance. Our data source was the Truven MarketScan database linked to the Health Productivity and Management database from 2017 to 2019. And we identified adults aged 19 to 64 who underwent 1 of 20 common surgical procedures, including cardiothoracic, vascular, orthopedic, and general GI surgery. Our analysis included multivariable regression models and 4-to-1 propensity score matching to compare our surgical cohort to their matched controls. Our outcomes were clinical, financial, and workforce related. Clinical outcomes included length of stay, inpatient complications, ICU use, and discharge disposition. Our financial outcomes included total payer spending and out-of-pocket spending in the 6 months after surgery. And our workforce outcomes included missed work and disability in the 6 months after surgery. And for this presentation, I'll mainly be focusing on out-of-pocket spending, missed work, and disability in the 6 months after surgery. We identified a total of 135,480 patients who had one of these 20 common surgical procedures from 2017 to 2019, of which 5,005 were linked to the health productivity and management data. Among our total surgical cohort, 25% were admitted through the emergency department. The median length of stay was 2 days. 12% had an admission to the ICU. 7% had a complication, and the majority of patients were discharged home postoperatively. This is a breakdown of the surgeries that we included in our cohort. The blue represents the cardiothoracic, orange is vascular, green is orthopedic, and yellow is general GI surgery. The most common were bariatric and knee at 21%, followed by hip at 16% and cholecystectomy at 11%. And overall, this represents a really broad and heterogeneous group of procedures that have previously been used as a representative sample of patients who need surgical care. When examining our financial outcomes, we found that surgical patients have high out-of-pocket spending in the 6 months after surgery compared to their matched controls, a difference of almost $3,000 in the 6 months after surgery. Surgical patients also missed more work, with 62% of surgical patients having any missed work compared to 33% of their controls, for a difference of about 30%. Surgical patients missed a mean of 23 working days for a difference of about a month of working days, or 20 days. We then examined missed work variation by the type of surgery the patient had, and found that patients who had an orthopedic surgery had the highest any amount of missed work. However, GI surgery had the highest mean missed days of work at 35 days. We also found that surgical patients frequently take short-term disability in the 6 months after their surgery, with 36% of surgical patients having taken any short-term disability compared to 3% of their controls, or about a 10-fold increase in taking any disability. And surgical patients took a mean of 41 days of disability. We then examined short-term disability use by the type of surgery, and again found that orthopedic had the highest use of any disability, but GI surgery had the greatest mean days of disability at 58 days. When examining which covariates were associated with higher out-of-pocket spending, we found that surgical patients with ICU or ED use had higher out-of-pocket spending in the 6 months after surgery. ICU use was associated with 2.2 times higher out-of-pocket spending, and ED use was associated with 2.7 times out-of-pocket spending. We also found that ICU and ED use were associated with any short-term disability use, for an adjusted odds ratio of 1.24 for ED use and 1.18 for ICU use. ICU and ED use were also associated with greater days of disability, an increase of 11 days if the patient was admitted to the ICU, and 6 days if the patient was admitted to the ED. In conclusion, in this analysis of a commercial insurance database of working age adults who underwent a common surgical procedure, we found that surgical patients had almost $3,000 in out-of-pocket payments in the 6 months after surgery, that they missed over a month of work on average, and that 1 in 3 received short-term disability benefits in the 6 months after surgery. In addition, we also found that ICU and ED use were associated with higher spending, greater missed work, and greater short-term disability. The financial impact of surgery is significant, especially in the context of the United States, where less than half of Americans have $1,000 to cover an emergency expense out of their savings. In order for all patients to have the opportunity to recover from their surgery and return to the workforce and have optimal outcomes, greater financial protection is needed. And I just want to end on a huge thank you to the team that I've been working with at the University of Michigan, and I'm happy to take any questions.
So Kathryn, I guess it's not surprising that patients that have surgery are high needs and have high costs. So within those patients, are you able to look at like who's at the greatest risk for having financial toxicity? Like, is it all patients who have insurance, or are there some characteristics within that group where you may be able to focus your like you say, providing some extra resources?
Yeah, thank you. I think not with this project specifically, but Charles has also looked into that question of like which patients are most at risk of financial toxicity, and I have as well with John Scott. We share a mentor. But I think that it's typically the lower income patients that are just above the threshold for Medicaid, so they have some amount of cost sharing, but they still are sort of low income that they're not able to cover those costs of medical care in general. So kind of like the higher of the low income patients are typically at most risk of having this financial toxicity or catastrophic health expenditures.
This was a wonderful talk. Thank you very much. I just want to, my question was actually very similar to David's. You know, you are describing a ubiquitous problem, right? And while that is probably something that policy can address, as healthcare providers, we can identify those at greatest risk. So one of the questions I have here to add on to David, the Truven market scan, does it have zip code information? Would you be able to look at the social determinants of health based on geography? I doubt they have racial information as an administrative data set. So I was just curious if you have that available.
I believe, I'm not totally sure, but I believe it does have zip code. And I know there's other projects, not this one specifically, but using something like the Social Vulnerability Index or the Area Deprivation Index to link to zip codes. But I think that that's really important to look at how the built environment or the neighborhoods patients are coming from are affecting their outcomes in terms of their clinical outcomes and their financial outcomes after surgery, for sure.
Yeah, congratulations. Really nice work.
One more question. Is that okay? Really, really awesome presentation, Kathryn. As you know, like we've all seen as providers, and we know too that like often the biggest cost to patients are the indirect costs, the missed work, this kind of stuff, rather than the direct out-of-pocket costs. But there's tons of studies on like out-of-pocket spending, which is the direct cost. I've seen very few studies of the indirect cost. My question for you is just trying to understand your data source a little bit better. It sounds like this is like continuously commercially insured people. Are you able to look in this group at all at people who lost insurance or stopped working as a result of their surgery?
That's a great question. I think for this cohort specifically, we only looked at people who were continuously enrolled for the 12 months before and after. And I think looking at like who missed work or outside of that would be like a really important part. But for this project, we just looked at patients that were continuously enrolled for insurance to try to see of these working age adults that have their insurance through their employer, what's happening to them, how much disability are they taking, and how much missed work do they have.
I also had one follow-up question. You know, there's a lot, and when we talk about out-of-pocket spending, there's a lot of discussion today on how high a deductible is in a health plan, high versus low deductible. Are you able to tease out of the patients that you would assume have the greatest financial toxicity, i.e. those that had the greatest financial liability and lost work, how many of those patients were in high versus low deductible health plans?
Yes, we actually, that was one of our like covariates we included in our regression, is whether the patient had a high deductible health plan or not. And it didn't reach statistical significance, which we actually found surprising. But I think we were the sort of next steps wanting to look at access sensitive conditions or patients that could present with an emergency condition that could be treated in an elective sense, and see which of those patients had a high deductible plan to see how that's affecting whether they present to the hospital on time or not. But for this project, we found that it wasn't significant for their out-of-pocket costs or missed work.
Great job, Dr. Taylor. Okay. Our next presenter is Dr. Thomas Handley, who will present, despite increasing costs, perfusion machines expand the donor pool of livers and could save lives.
Hello, everyone. My name's Tom Handley. I wanted to start by thanking you for inviting me here today. I'm excited to share our work on normothermic machine perfusion, which looks at determining how many additional organs might be possible using machine perfusion, and whether use of such technology would be cost effective. I'd like to start by giving thanks to Dr. Melcher, who's helped mentor the project, as well as Dr. Morris and Dr. Wagner, who helped with some of the early stages in the revision of the manuscript, and Kate, who's helped with the statistical analysis. So many of you here today may look after patients with liver disease. The need for this care is only going to increase in the near future. Over the last 40 years, the incidence of liver disease has risen by around 400% worldwide. Liver transplant remains a highly successful treatment for liver failure, but demand far exceeds supply. Almost 32% of patients who are listed leave the waitlist within 3 years because they become too sick or die. Yet we still waste organs every year. Thousands of organs are known to be discarded, and finding ways to increase the potential number of organs that we could use could give the potential to increase that supply to meet demand. Several recent studies have shown that previously discarded organs, if they received machine perfusion, could have potentially been transplanted. This technology perfuses the liver with blood and provides measures of levels of nutrients and markers of damage, allowing a more objective assessment of donor quality. 2 recent trials, for example, one of which randomized 220 livers to patients either receiving machine perfusion or normal cold storage, showed that the machine perfusion reduced graft injury by about 50%. Another study showed that of the livers that were perfused, 71% were transplanted, and with 100% survival after the operation at 90 days. However, we still don't know how many additional organs could potentially be used for this type of transplant. It remains to be seen how many organs would be available, how much this would cost, and how effective such a strategy would be. Our study aims to find ways of estimating that how many additional transplants could be used if we use normothermic machine perfusion in this way, using the vital trial criteria on a US national data set. We also then seek to study the costs and benefits of such a strategy to see if it would be effective. We identified potentially eligible livers using the Scientific Registry of Transplant Recipients national data set between 2009 and 2019. Organs were included if they were considered for transplant but not used. We then used the vital trial criteria to exclude organs based on a variety of donor contraindications and logistical issues, and then predicted the yield of transplants to try and calculate the total number of organs that might potentially be able to be used. We then used the output from this data analysis to develop a Markov model. A Markov model is a decision analysis tool which uses systematic quantitative approach to decision-making under uncertainty. Patients enter and progress through various health states, such as being well, developing sickness, and then dying. And then that results in a primary outcome. Our outcome were costs in US dollars, quality adjusted life years, which is a measure of quantity of life in terms of years and how good quality that life is, like with 1 being perfect, 1 year of perfect quality life, and resulting incremental cost effectiveness ratio, which is effectively these numbers divided by each other. Our model is illustrated here on the right, which shows patients progressing through various health states and various criteria, accruing costs and quality adjusted life years as they move. And we compared 2 competing strategies, static cold storage, which is the status quo, it's what we use at the moment, and static cold storage and normothermic machine perfusion of discards. We looked over a 10-year study period of a hypothetical US cohort, which starts on the wait list, and we used a willingness to pay threshold of $50,000. The willingness to pay threshold is effectively a marker of roughly what a healthcare payer would be willing to pay for 1 year of quality adjusted life. This figure shows some of the results from our data analysis. It's a consort kind of consort diagram, which presents the results or compares the results on the left-hand side of the vital trial to our data analysis on the right. Of almost 2,000 organs which are available on average each year that are discarded or not retrieved, 383 would be potentially available for transplant. That represents an almost 5% increase in the total number of transplants per year. This table represents the output of our Markov model, which shows that although the normothermic machine perfusion strategy would increase costs slightly, it also increases the number of quality adjusted life years and is below our willingness to pay threshold, so we can say that it is cost effective. This number on the right is just highlighting that it's below the 50,000 threshold. This diagram displays a tornado plot, which is used to display each of the sensitivity analyses that we use to check the robustness of our model. They're ranked in terms of how much they affect our conclusions from top to bottom, where top being the actual cost of treating a patient on the wait list. You can see here the red arrow marks the 50,000 per quality adjusted life year threshold and shows that it gives us effectively a break point in our model, which means that above certain thresholds, the model is no longer effective. So what does this mean? Our analysis suggests that using normothermic machine perfusion in this way could increase the number of transplants potentially available by about 5%. It was cost effective at our willingness to pay threshold by reducing the number of patients that remain on the wait list and accrue lots of costs. When the cost of the normothermic machine perfusion exceeded $231,000, that is effectively above our willingness to pay threshold. However, these willingness to pay thresholds are fairly subjective. Different studies use different markers. And if the willingness to pay threshold is increased to $100,000, for example, the normothermic machine perfusion would be cost effective until it exceeds $286,000. One of the main limitations of our study is that we're not able to quantify some of the indirect benefits of this technology. For example, using the technology may increase the out-of-body time for the organs, which could enable what were previously emergency operations to be elective. That could reduce emergency operating mortality and morbidity, which accrues costs to the system. It also gives the potential to increase our transport distance, which would enable us to potentially merge regional wait lists and could have some efficiency gains. The SRTR database also lacks some granularity. For example, we're not sure that organs that we think might be eligible would actually be eligible, but our model was relatively insensitive to that particular parameter, and we think that it would still likely be cost effective. Future work could compare strategies for normothermic machine perfusion, what the best way of implementing it is, and how we can use them during our retrieval operations. So in summary, 5% of our livers would likely be, there would be an increase of about 5% of organs if we use the technology in this way. We think that using the technology is likely to be cost effective, and wider use of normothermic perfusion could improve access to what is a life-saving care. I just wanted to say thank you, and I'd welcome any questions.
Hi. Hello? Oh, okay, perfect. So I just had a question about your choice for a 10-year time horizon. In a way, it seems like you're already showing a benefit to the procedure within 10 years. So perhaps you can assume that if you modeled more on like a lifetime scale, that you'd continue to do so. But was there any sort of thoughts you had about possibly doing a longer time horizon, or did you feel like this adequately captured the clinical course of this patient population?
I think we chose 10 years because it would capture the likely benefit from patients. Patients when they enter the transplant waitlist are probably less likely to last 10 years. So we felt that using the model in this way captured effectively the clinical window of people waiting on the wait list, having a transplant, and then surviving or dying. And so we were able to capture the costs and benefits of it. That's why we chose 10 years.
Thank you. This was really wonderful. I too believe in machine perfusion. I guess I have two questions. One is this something that you guys are doing? And one of the things that might be interesting to look at, in addition, with the machine perfusion, normothermic machine perfusion, also comes the ability to actually defat livers. So livers that are presently considered non-transplantable have shown to be, if you treat them for a few hours, actually are transplantable and don't lead to primary non-graft function. And so I'm curious if you have looked at that, and otherwise it might be interesting to do that.
Well, I think, interestingly, Dr. Melcher told me that the first normothermic machine perfusion transplant happened at Transplant, I think, just this last week, if that's correct. So that's something that should be celebrated, I think. In terms of kind of rehabilitating livers that were previously not considered transplantable, that wasn't something that we considered in this study, but I think it's certainly something that I think could, again, increase the potential for the number of organs that could be used. So it's something that I would be in favor of. Yeah.
Tom, one quick question. For your excuse me, cost calculation in the ICER, does that kind of assume that these machines would be available at all places? So in other words, is it possible to factor in the logistics of actually making these machines available when you're calculating the ICER?
So yeah, one of the future directions for the research is essentially where we should place machines. Should they be, some of the different manufacturers have different types of machines, one that might need to be institutionally based, whereas other manufacturers could, for example, go on retrieval runs with the machine, like the Transmedics machine is transported. So exactly how to implement machines most cost effectively still is a kind of a future area of research. But our study effectively incorporates the cost per run of using a machine rather than like the best location for them.
Hello. Hey, Tom. Great presentation. Quick question. So kind of to bounce off Dr. Laudner's point, are these something that you see being used for all liver transplants ever, or just more for sicker livers or for healthy livers as well? What do you think?
So I think interestingly, after we designed this study, a study was released in January, which compared, it was called the Protect trial, compared deceased donor to all livers being undergoing machine perfusion, and their conclusions were that machine perfusion outperformed static cold storage. If that's the case, then every liver should be undergoing machine perfusion. Again, I think that's something that we should consider in the future. And I'd like to do another cost effectiveness analysis on it. Yeah. So
That's actually, so there's a precedent, right? We now do this for kidney, and it allows us to pump the kidneys and do them during daytime. And in fact, these pumped kidneys in European studies have shown this extensively. They perform better. They kind of break the spasms. There's a lot of precedent to believe that we'd have similar effect in livers. And as a liver transplant surgeon, I'm biased. It would be nice to do them between 6 a.m. and 6 p.m.
Actually, Tom, this is really great work, and I have a question alluding to what Dr. Spain was just heckling. So, I wonder if there's a mechanism for, or if you have an idea of how to look at how you would save costs by not doing liver transplants in an unpredictable fashion. Because if nursing knew the night before and we had extra rooms available to do it between 6 to 6, is that cost saving, or does it cost more money to have an extra OR running?
That's a good question. Yeah, I think that basically we're going to have to try and carefully calculate what's best to optimize, whether it's best to optimize for round-the-clock surgical OR use time, or whether it's best to optimize for areas where we know that, for example, other procedures where you might operate out of hours, we know are related to higher morbidity and mortality. Like there's something called NCPOD in the UK, where we know that emergency operations are associated with higher risk of death. If the health system is effectively going to try and have to incorporate that into its calculations, that there might be higher risks of either complications, which lead to ITU stays, to doing out of hours operating, it might be more cost effective to do all operating within hours, or it could be more cost effective to kind of spread that out through the day and the night if you can schedule it and people are going to have the right sleep schedules. And I just think that's a huge area of research that is really interesting, but I can't say that I have the answer.
To that.
Excellent. Thank you, Dr. Handley. Appreciate it. Next, we'll invite Dan Stoltz, who's going to speak about technical variant liver grafts show equal graft survival to whole liver grafts in pediatric liver transplantation at high volume transplant centers.
Thank you for the opportunity to share our research today. My name is Dan Stoltz, and I'm a Stanford general surgery resident. We have no disclosures. Despite efforts to improve pediatric priority and liver organ allocation, pediatric liver transplant candidates remain disadvantaged because of a lack of size-matched donors. Each year in the United States, 1 in 10 infants and 1 in 20 children still die on the wait list. Additionally, delays in liver transplantation have unique consequences for waitlisted pediatric patients. Technical variant liver transplantation, a term used to encompass surgical techniques that utilize deceased donor split liver grafts, deceased donor reduced sized grafts, and live donor grafts, has been proposed as one strategy to address the organ shortage by giving transplant opportunities to more patients in a timely manner. Despite these potential benefits, technical variant use in the United States remains stagnant and is utilized at significantly lower rates than European countries. European reliance on technical variants has been a necessity to face a severe shortage of full-size grafts from pediatric donors for decades, prompting implementation of various country-specific splitting policies that have been associated with increased technical variant use and consequent reductions in pediatric waitlist mortality. As pediatric patients continued to die on the waitlist in the United States, we sought to better understand the role that transplant volume at individual transplant centers may have on the utilization of whole and technical variant grafts. Additionally, we evaluated if transplant center volume and use of technical variants affect pediatric liver transplant outcomes. Similar to our last presentation, we used the SRTR database, and pediatric liver-only transplant recipients in the United States were queried from 2010 through 2020 and included in the study population. Individual transplant centers were divided into high and low volume groups based on the average number of pediatric liver transplants performed per year over the study period. We compared demographic and clinical characteristics between the high and low volume centers. Overall graft survival was compared, and Cox proportional hazards models were then used to identify independent predictors of graft failure. Over the study period, 5,208 patients met inclusion criteria to comprise the final cohort. 17% were transplanted at 73 low volume transplant centers, and 83% were transplanted at 31 high volume transplant centers. These bar charts demonstrate the frequency of transplant procedures by graft type, with orange and yellow representing technical variant grafts and blue representing whole grafts. The 73 low volume centers are seen on the left, and the 31 high volume centers are seen on the right. High volume centers accounted for the majority of technical variant liver transplants performed. Technical variant liver transplantation was more likely to be performed at high volume centers. And when technical variant liver transplantation was performed, there was no observable difference in usage rates of split liver grafts or live donor grafts between high and low volume centers. However, high volume centers were significantly more likely to utilize reduced size grafts compared to low volume centers. Patients transplanted at high volume centers were younger and weighed less than patients at low volume centers, while patients at low volume centers were transplanted at higher MELD and PELD scores, were more likely to be listed as status 1A, and were more likely to require vasoactive support or mechanical ventilation prior to transplant. We observed no difference in cold ischemia time or the percentage of live donors between these groups. High volume centers were able to both initially list and then subsequently transplant pediatric patients at significantly lower MELD and PELD scores compared to low volume centers, as demonstrated by this series of box plots. This indicates that high volume centers were able to consistently achieve timelier transplantation for pediatric candidates earlier in their disease course. And this may partially be explained by recipients at high volume centers having access to more organs, given the increased use of technical variant liver transplantation compared to low volume centers. Overall graft survival was calculated for whole grafts and technical variant grafts up to 3 years post-transplant and was further stratified by high volume and low volume centers. At high volume centers, there was no significant difference in graft survival between whole grafts and technical variant grafts. Whole grafts at high volume centers demonstrated significantly improved graft survival compared to low volume centers. Similarly, technical variant grafts at high volume centers also demonstrated significantly improved graft survival compared to low volume centers. Interestingly, technical variant grafts at high volume centers also demonstrated significantly improved graft survival compared to whole grafts at low volume centers. And at low volume centers, whole grafts had improved graft survival compared to technical variant grafts. In our Cox proportional hazards analysis, receiving a liver transplant at a low volume center was the only covariate significantly associated with graft failure. This relationship was observed both in patients less than 12 years of age with an adjusted hazard ratio of 1.6, and in patients 12 years of age or older with an adjusted hazard ratio of 1.8. Waitlist mortality of pediatric liver transplant candidates added to the waitlist during the study period was similar at high and low volume centers. And there was no significant difference in waitlist time of transplanted patients between the two groups. There are several limitations to this study that I'd like to point out. Using transplant center volume as a proxy for experience does not fully capture experience at an individual surgeon level. Unfortunately, this granularity was not available in the SRTR database. And we also did not examine outcomes of adult recipients who received the remaining portion of split liver grafts. In conclusion, we demonstrate equivalent graft survival between whole and technical variant grafts at high volume transplant centers in the United States who perform on average, or an average of 5 or greater pediatric liver transplants per year. With 30% of donor offer refusals citing size mismatch, increased use of technical variant grafts by experienced transplant centers represents an opportunity to transplant more pediatric patients in a timelier manner. We also demonstrated that graft survival for whole and technical variant grafts at low volume centers is currently inferior to graft survival at high volume centers, highlighting the importance of experience level at individual centers. Greater education in surgical techniques is needed at low volume centers to facilitate better outcomes, particularly for technical variant liver transplantation. Thank you again for the opportunity to share our research. I'd like to thank Dr. Gallo and Dr. Bonham, as well as the other members of our team, including Grant Lum, who is not here today, but thank you.
While we're waiting for further questions, one quick thing. So in determining high versus low volume, did you do any sensitivity analysis kind of playing around with where you move that bar, or leaving volume maybe as a continuous variable and see if there's an effect there?
Yeah, we originally chose that based on previous literature that has designated low or very low volume centers either in the United States or in Europe. As a starting point, but I think it would be interesting to break up the groups potentially even further. I think we were a little concerned about our sample size and being able to compare things at a multivariate level with sufficient enough patients in each group.
Dan, great presentation. So do you think this has policy implications into who should be doing pediatric liver transplants? Because it seems like that was your biggest signal, was the volume rather than the type of graft that you used.
Yeah, so I think at a minimum, it's a contentious issue because there's trade-offs for consolidating care into several high volumes or very high volume centers. I think the number one concern being access to transplantation. Another proponent for consolidating care is that it may provide a better training experience for transplant surgeons who then may be more comfortable to then go out in the community and perform these technical variants on their own.
Can I ask a kind of question off of, to follow up on that. So some of this will be surgeon experience and technique, but some of it will be the care team. And so is part of the problem at the low volume centers that they might not have care teams that can optimize things, or they're seeing patients who might have issues with out-of-pocket costs or other things that might be affecting survival?
Yeah, I think it's difficult from our data to tease out what is attributable to an individual surgeon's experience as opposed to the institutional memory or policies of a particular center. There is OPTN policy that requires a designated pediatric transplant facility to have a pediatric transplant surgeon that has performed a certain number of pediatric transplants. But unfortunately, we don't have that granularity within the SRTR database. So this was our closest proxy.
All right, great work. Thank you, Dr. Stoltz. Our next presenter is Dr. Vivian Ho, who will present on remote access to electronic medical records reduces overall EMR time for vascular surgery residents.
Hello, thank you for the privilege of the podium. So electronic medical records, we love them, we hate them, partially because they provide convenience, they provide portability, but they also dominate our time. They complicate our relationship with our patients, especially now as documentation has gotten more transparent. This table is actually from a paper authored by our Chief Wellness Officer, Dr. Tate Shanafelt, demonstrating that physicians using EMR were independently more likely to be dissatisfied with patient care and more likely to have aspects of burnout, and that's been capitulated in the resident literature as well, often citing administrative burdens and time with the EMR as being associated with resident burnout. Actually, there's a study coming out of the educational fellows here at Stanford that included a survey of 229 residents who estimated that they were spending anywhere from 4.6 hours to 13.6 hours a day on the EMR, and that just sort of depended on whether you were a chief resident or an intern. So one of the downsides of the EMR is all the documentation we do, but there are also databases created by the EMR that we can take advantage of. So EMRs naturally track user activity to prevent illegal access, to make sure you're not looking at Britney Spears' records, but we can actually use this data byproduct. And our interest in this project was to see if we could look and characterize resident behavior in the EMR to try to make a more user-friendly experience. So we had a couple hypotheses. First, we suggested that possibly objective measures of EMR time will probably be lower than self-reported estimates, and that has nothing to do with being disingenuous. It has more to do with the fact that when you're doing something that's unpleasant, it just feels like it takes longer. Residents, we also thought, might use remote access functionalities, might spend less time using the EMR. Folks who have it on their phone, who don't need to go to a workstation, that might actually lead to time savings up front. And then I'll also be honest that I have a bit of an ulterior motive in presenting this, is because none of these findings that I'm about to present are really unique to being on a vascular surgery service. I'm just a vascular surgery resident, so this is the field that I started with. But I think there's a lot of great opportunity for collaboration now that the pipeline's built to extend this to other services. So we extracted weekday, non-holiday EMR activity for all residents who passed through the vascular surgery service at Stanford Hospital from July 2015 to 2019. That constituted 53 residents, so it wasn't just vascular surgery integrated residents. So plastics, ENT, ortho, pretty much everyone here who's representing a service, your residents have been on our service. And we extracted daily time spent, who the resident was, their postgraduate year at the time of access, and then whether they accessed remotely. We also controlled for patient census and operative caseload to try to get a sense of what the type of patient burden was that day. Our statistical analysis was using a linear mixed effects model, which is handy because it allows us to sort of analyze how different covariates may vary in their impact amongst different groups. So if we grouped each person as the individual resident, we could also adjust in a random slope for patient census, understanding that different residents are just going to have different methods and attitudes about navigating the EMR, but at the same time also account for things like PGY level, academic year, and the fractional time spent remotely. So just on a very superficial level, The mean daily EMR usage here at Stanford ranged from 1.1 hours, according to chief residents, to 3.6 hours by interns. So that's about 30 to 35% of the amount of time reported by prior survey means. But I think it's a little more useful to visualize sort of where the day goes. So across PGY level, the blue and the orange are chart review and note review activities. Those correspond to these like tabs in Epic that every resident is going to know very well already. And so across PGY level, residents are spending about 75% of their time in the EMR just reviewing information. And there is some hope for the future, suggesting that patterns have somewhat improved. So mean daily EMR usage fell by 36 minutes from the first year of the study period to the last academic year, 2018 to 2019. And if we look at who's driving that change, you can see that generally the senior residents, they're probably spending the most time in the operating room. They're mostly spending about an hour per day on the EMR, but it's variations in junior and mid-level resident activity that are really driving that change that I first cited about academic years. So in using a linear mixed effects model to evaluate the effects of different covariates adjusted by resident and academic year and PGY level, we found that increased usage via remote access continued to be associated with reduced EMR time. And so one thing I want to reference again is our consistent finding that EMR time objectively averaged about 1/3 of subjective EMR estimates. And this is sort of a figure that's from a very classic psychology study where you apply a stimulus to someone that angers them, and they feel that it's at a 1-second stimulus feels 50% longer because they're angry. Very similar with a fear stimulus, you apply a stimulus to someone that makes them afraid for a minute, and they feel like it's 30% longer. So this is very consistent amongst prior work with attending physicians. Attending physicians also seemed to estimate about 30 to 40% of their true EMR time. And I think has to do more with the negative experience that people are having using the EMR. It's more of a sign that we have to improve the interface for everyone, as opposed to say, well, actually, you're not spending as much time on the EMR as you think you are. Get over it. So we wanted to further parse out how remote access might actually save people time using the data that we have. So one thing we did was we did restrict this data point to the workday to avoid collecting sort of people like going home, being worried about their ICU patient, checking on their phone about that. And so this is literally when people are in the hospital, they're still using these remote access technologies, and the relationship between remote access and time saving still persists. And I think one possibly good explanation is that residents who are using remote methods are probably saving time on what they do the most in the EMR, which is chart review. So if you're just looking at a note, if you're just looking at a lab result, you can do that on your phone, as opposed to pulling it all up on a workstation. That can ultimately save you time. So some limitations about this work, we're not adjusted for patient comorbidity. So we did do patient census, but obviously if you have sick folks, you're going to be more busy. And then this is a small sample size, 53 residents with 1 surgical service. But ultimately, our hope is that we can talk to other services about including you guys in this kind of work. And that would allow us to do some semi-controlled studies on some interesting interventions, like whether APPs change resident workloads, how different call schedules change resident activity. And I think that could be really fun. All right, thank you.
No. Sorry, Vivian, great study. So, and I'm a little bit dangerous with haiku, but I find that it's so much easier to find the information on there than when you log into Epic. And so when you get to that concept of the interface, is there just like too much in Epic when you go online that we only use 10% of all the things available to us? And that's where we need to focus on making it more user-friendly to the physicians.
I definitely agree with one of the constraints and sources of frustration with the EMR being lack of usability. I think there's a lot of great studies to suggest that when you bring the more important information to the forefront, when you reduce the number of clicks it takes to navigate through something, you greatly reduce the associated cognitive burden with these tools. So it's a little unfortunate that a lot of these EMR interfaces weren't created with users in mind, but I definitely think what you're saying is consistent with negotiating that time that people spend and the perception of that time.
Very nice work. It's really interesting. I actually have two questions. One, for the background data, you showed a graph with some numbers, and maybe correct me if I'm wrong. I saw that the number of people who actually don't use EMRs was very, very small compared to those who do. I would presume that in 2022, that's really a fundamentally different cohort, because most hospital systems around the country now have EMRs, which wasn't the case 20 years ago, let's say. And so I guess my question is this today, or is this a pre-post kind of comparison, and was this adjusted to all the other factors that I will presume these centers are different? And my second question is actually, so there seems to be this dissatisfaction going through EHR. I remember having to go and get films and going walking across the hospital. And so personally, I'm elated that I can just press a button and now see a whole CT without having to schlep films. And I guess that's just a different experience and different comparison. So what do you think going forward? So there seems to be this agreement, no matter what the background data is, that it's not really fun to go into EHR. Yet that is where the information sits that we need to take care of patients, right? A lot of what you show is about taking care of patients. So what is really the future? How do you feel this could be resolved? So the time spent to take care of patients, which is our objective, is perceived as more fun.
Thank you for those questions. I'll probably answer your second one first, just because I like to talk about fun. I think that many of these tasks, this is specifically a resident level study, and I think that's because we care a lot about how much residents get experience in the OR, right? So unlike medicine residents, where there's time spent in the EMR, yeah, we don't want them to spend crazy amounts of time, but they're probably doing patient work. We need surgical residents to go to the OR, operate, and learn to be great surgeons. So I think for the perspective of satisfaction amongst residents, there's been a lot of studies about adding APPs to teams to automate or to offload some of the administrative burden. But then the other thing is that I think a lot of this stuff can be automated. And I think some of the research already presented earlier today has shown that how you can extract ICD codes, et cetera, but there's a lot of administrative burden that still we ask physicians to do in the medical record because we need someone with some clinical acumen to do it, but we don't actually need someone who has an MD. And so I think as automated tools become more prevalent, just as when you start typing into Google, it seems to already know what you're going to ask. I think like pre-fill texts, more user-friendly automated tools like that can lead to greater satisfaction for not just residents, just folks trying to get things done for patients and not spending time documenting. With regards to this sort of time difference, is this the table that you were referring to? Okay, yeah, so that was a very helpful call out. This is actually, as you point out, this is from 2004, the Schoenfeld paper. The survey for residents was from 2018, and so that data as to the estimates of how much people think they're spending time on the medical record is more updated, and it's also contemporaneous with our analysis, which was 2015 to 2019. And so, although I was sort of using that table to make a point about how people can find the EMR to be a contributor to burnout, I think our findings within our resident group were contemporaneous with the survey data we compared it to.
All right.
Time for another question?
Yeah, sure. Dr. Sachs-Harris, yep.
Thank you for an interesting and well-presented study. So you can cut down, you can save time by not doing things that you should do. And so is there a way in your work to incorporate some element of the quality of EMR use as well as time?
I think that's an awesome question. I don't think based on the data that we purely extracted in this case, we would just be able to say where you were. The extended way to answer that question would be to somehow link it to measures of resident performance, which would be somewhat external. That would be based on like ratings that you get every month or every clinical rotation. And then an even more distant, but maybe just as interesting would be to link it to patient outcomes. But you'd have to comorbidity match as well for that, for sure. But thanks
All
for
right,
asking.
another round of applause for Dr. Ho. Thank you. Next up, we'll invite Raja Narayan, who's going to be speaking about machine learning can predict recurrence patterns after liver transplantation in hepatocellular carcinoma patients. Analysis from the U.S. Multicenter HCC Transplant Consortium.
Good afternoon. Hi there. It's an honor to be able to present our work with you today amongst these awesome talks so far, and also to be away from the EMR. Unfortunately, I have no financial disclosures. So as many folks here know, hepatocellular carcinoma is one of the fastest growing causes of cancer death in the United States, and a fifth of all liver transplantations in the US are done for HCC. To expand the pool of candidates that can receive a liver, local regional therapies can apply that include ablation, TACE, and liver resection as well. However, in a small cohort of patients after transplantation, a recurrence can occur, and it's unclear which features regarding the patient will be associated with liver recurrence versus extrahepatic recurrence. It also is unclear whether liver or extrahepatic recurrence is associated with a greater risk for mortality. In this study, we sought to use machine learning to identify and answer these questions using a large data set. So using a data set that was put together by one of our colleagues at UCLA, Dr. Vach Agopian, we looked at consecutive HCC patients that were transplanted at 20 centers across the United States between 2002 to 2013 that encompassed all 10 of all 11 UNOS regions. We also employed random forest classification, which is a machine learning strategy where you take a data set as shown here, and then you analyze different features that are included. Show up here if you can see. And each feature is then queried for whether this is associated with a certain output from the feature. For example, is the patient within Milan criteria or outside of Milan criteria? And then the next feature is asked, does this person's AFP less than 200 or is it greater than 200? And thus a prediction is made using a random assortment of the features available in the data set. For this study, we did 10-fold cross-validation that was used over 90% for training, and then subsequently a prediction was generated from the testing set, and an average was then taken to answer the question of whether recurrence would be predicted or not. So for this study, we had over 4,900 patients for which 12% developed some type of recurrence. We found that a third of patients recurred in the liver and 73% recurred outside of the liver with some degree of overlap. First, there was 23% of patients that only recurred in the liver, 63% of patients that only recurred in the extrahepatic environment, and about 11% of patients recurred in both spaces, leaving about 88% of patients that had no evidence of disease on last follow-up. This is a small representation of the baseline characteristics of patients that had a median age of 58. Most notably, about 72% of patients had some type of local regional therapy, for which TACE was the most commonly applied modality, used in about 57% of patients. We found that the laboratory meld for this cohort had a median of 13 with a broad range as shown here. The last pre-transplant AFP had a median of 9.8 with a very broad range going up to 45,000, which is well beyond what transplant criteria would be, at least at our institution. And the same can be said about the maximum pre-transplant AFP with a median of 18.3 going as high as 300,000. This plot shows the different liver diseases patients had, the recipients had prior to transplantation to see whether they were associated with certain types of recurrence patterns, where dark blue is any recurrence, gray is liver recurrence, and light blue is extrahepatic recurrence. And as you can see, none of the liver diseases achieved greater than 20% risk for recurrence in any of the types of fields or patterns. We then looked at only those patients that recurred and found interestingly that patients that had autoimmune hepatitis and other diseases, which predominantly included metabolic disorders, tended to have more only liver recurrences, which may be related to the fact that they had a persistent systemic disease following transplantation that could modify the environment in the liver. This is a competing risk analysis that looks at the different liver patterns, recurrence patterns, to see which were associated with mortality, as shown on the y-axis. Because these are competing risks, these are mutually exclusive events. And as you might predict, patients that had no evidence of recurrence or death without recurrence in the green had the lowest risk for mortality, whereas those that recurred both in and outside of the liver had the greatest risk, and those that only recurred in the liver or outside the liver, interestingly, had a similar risk for mortality. We then charted a receiver-operator characteristic plot looking at the AUC for a random forest model predicting the outcome, in this case for this plot, of any recurrence, and found that to be 0.78 when including explant features, but when only looking at pre-transplant features, this dropped 0.73. We then looked at a Shapley plot that I've shown here that along the y-axis ranks the features included in the dataset by those most important and related to the outcome of interest, meaning recurrence, versus those least important. And notably, tumor biology factors like AFP or whether the patient met or exceeded Milan criteria were the most important features here. The x-axis represents Shapley values, where the more positive value here was associated with a greater contribution to the outcome of recurrence. 0 had no association, and a negative value protected against the outcome of recurrence. And for the different outcomes or outputs that you can get from each feature, there was a gradient that was shown here that could have a binary outcome. For example, did the patient have a hepatectomy? If yes, as shown as red, there was a greater risk for recurrence. If no, in blue, there was a 0 contribution to the outcome of recurrence. Whereas age at transplantation, as you can see, has a gradient where younger patients that were alive for longer after transplantation had a larger risk for recurrence in any field. We then looked at the outcome of liver recurrence. With explant features, the AUC was 0.77, and without, it was 0.75. The Shapley plot also showed the same features at the very top, including tumor biology factors. And then of note, and you could see this on the prior plot as well, local regional therapies did not substantially increase their risk for recurrence in the liver, which makes sense because this is a donor liver we're talking about. Then when looking at extrahepatic recurrence with explant features, the AUC was 0.75, and without the explant features, that dropped to 0.73. The Shapley plot most notably showed the same biology factors at the top, but interestingly, neutrophil to lymphocyte ratio also made it to the top, which is a novel metric now that's being associated with tumor biology and potentially MELD score as well, whereas local regional therapies still were at the very bottom of this plot. So overall, we found that recurrence after liver transplantation for HCC is uncommon, but it's most commonly in the extrahepatic environment. We found that tumor biology factors like the AFP, the Milan criteria, whether they met it or exceeded it, as well as the neutrophil to lymphocyte ratio were the most predictive features of recurrence in all fields. But we also found that the drivers for these recurrence patterns seem to be similar after the native liver has been removed. And we need more information specifically about the donor liver and potentially about the recipient to clearly predict the recurrence patterns. There are inherent limitations to this retrospective study. But we found that, as I mentioned, some patients that were included may not meet transplant criteria at some institutions, such as having very high AFP values or those that were downstage or beyond Milan criteria at the time of transplantation. We also didn't have information about the donor, including whether they had hepatitis of some viral etiology that may allow for a persistent systemic disease after transplantation. We also didn't have information about whether the recipients received chemotherapy after their recurrence or what type of immunosuppression they had, which could modulate the environment in the liver and the opportunity for recurrence in a certain field. And lastly, this was done over a heterogeneous time period where, for example, hepatitis C was not curable, and in modern times where there is a cure for hepatitis C, which again could modify whether there is a systemic disease that can drive a difference for recurrence patterns in these patients. Thank you so much for your attention. I'm happy to take any questions you have.
Thank you, Dr. Narayan. That was excellent. So I guess in the event that you adopt this model to predict recurrence and you're having a conversation with the patient in front of you or their family about the ability to undergo a transplant, how much risk of recurrence are you willing to take as the transplant surgeon to offer them that surgery?
That's a really tough question. So it really does depend on kind of the resource as well of the competing requirement for other potential recipients that may benefit from the donor rather than this patient that you're counseling as well. And it depends on how sick that patient is too. So one of the thoughts or the hopes in the future is that this model would give you an idea of whether this patient is at an elevated risk, like you say, and then whether that risk is something that we can monitor for more effectively. And if there was a way that we can survey these patients and identify when a recurrence happens, that we can act on it in a way that we can also rescue that patient from a worse overall or long-term outcome. So depending on how great our surveillance strategies are, that may modify whether a high-risk recurrence patient may still be able to proceed for transplantation. And of course, the same things about whether the patient is so sick that this is really their only option left over. But there's a lot of considerations. It's really difficult to assign a number.
Thank you. This was a wonderful presentation. Maybe just as in transplant, you also have to consider the regulatory situation. Right? We're bound to at least 1-year outcomes, possibly 3-year outcomes in the future. But I got a question. In your limitation slide, you mentioned that there's some limitation because, for instance, AFP over 1,000 would be part of it in some patients and not others. So, and I'm sorry if I missed that, but is that information available, or it was simply not available? Because if it were available, you could probably adjust for it, right? Also, you could probably adjust for the timing. We know when hepatitis C treatment became fairly available, and there's kind of a pre and post adjustment. And so maybe you don't have the information there.
So those are really good points. So I'll answer your second question first. So yes, we could totally adjust for the time point in which patients underwent transplantation, but it's unclear if they were even treated before or after in the data set that we have. So that's one thing that would be a limitation if we were to do that too, but potentially could be employed to try and correct for that, as you mentioned. And regarding your first question, although we do have the last and the maximum pre-transplant AFP in this particular database, we don't have other values as well, so we don't know kind of where it trended. But you're totally right that we could exclude patients that did have a very high AFP at the last point before transplant or maximum, but that would also considerably shrink our cohort too.
Other talk as always, Raja. One quick question. I was wondering for your inputs, like the AFP, did you scale the inputs like on a more, because I saw that the range are pretty high, and I wonder if that affects the relatively lower kind of discrimination in the chat plot. So I was wondering if you if it was scaled, and if not, that could be considered. I think that could potentially boost the model performance.
Yeah, so that's a really great idea, and I think that's akin to what Dr. Laudner was mentioning as well, that it may be beneficial if we kind of group together folks that had really high AFP values that may either be excluded or in a separate group altogether, because just like you suggest, they certainly have different tumor biology than the rest of the cohort, and we may see that first line over there separate out in a different fashion, where you can come up with a different cut point. When you include everybody, it kind of makes things a little muddier. So we didn't do that in sort of a categorical way where you have different subsets of folks with AFP. We did it more as a continuous variable, but that's a great idea that we can try to incorporate in next steps. Appreciate that.
So I have a last question to leave you with, Dr. Narayan. To go back to Dr. Schechter's question, I wonder if you would even ever use this model based on the performance statistics, and whether you think that the performance is good enough to deploy this clinically. That's one question. The second is, because I know you've also worked on deep learning projects with Dr. Melcher. How much do you think projects like this, where you're using certain machine learning algorithms that are more explainable, help you understand more of the science behind your question versus the application of what you build?
Yeah, those are awesome questions, Dr. Ross. So leading to your first point, I really don't think that our model so far is like clinical ready, because I think is the 0.7-ish sort of score is still kind of subpar, but I think it also helped highlight where the missingness is, as we were talking about earlier for another project, that we don't have information on the recipient subsequently, or we don't have information on the donor liver as well, because we know that steatosis in a donor liver may also be associated with the risk of having HCC from patients with NASH. So having more information in that sense will create a more robust model that then will be clinically ready for use. So we have some ways to go, but I think this is our starting point that we can build off of. And regarding your second point, so I'm glad you mentioned that, because there has been more recent information, for example, with the neutrophil to lymphocyte ratio having a clinical relevance too, because it's still somewhat of a scientific thought or basic science sort of component in determining the risk for recurrence or a patient's tumor biology. But there have been some basic science reports that show that when you have an elevated NLR, that tends to be associated with IL-17 secretion, which can allow for HCC growth. And it also allows for tumor-associated macrophages to kind of flock to where the tumor is located, which can cause for angiogenesis. So it is a surrogate for tumor biology that hasn't been as well understood or characterized beyond what I've just mentioned, but it may be something that needs to be more importantly understood and incorporated with our decision-making in the future.
Great job.
Thanks.
Great job. Our last speaker for the clinical research section is Rizk, who will present on health equity ratings of U.S. burn centers. Does for-profit status matter?
Hi all, my name is Rizk. I'm a medical student here at Stanford, and today we'll be discussing health equity ratings of U.S. burn centers and whether or not for-profit status matters. We have no financial disclosures. For decades, we have accrued data that shows that social determinants of health, such as race, ethnicity, sex, gender, education, socioeconomic status, and more, impact healthcare outcomes in burn centers, specifically worse outcomes for marginalized communities. Burn injuries affect people indiscriminately, and it is crucial that patients with burn injuries receive the care they need, regardless of their social determinants of health. Institutions such as the World Health Organization, Centers for Disease Control and Prevention, and the United States Department of Health and Human Resources have been developing commissions, forums, and reports to mediate and investigate differences in health disparities. The Lown Institute provides publicly available data, including a health equity score parameter, as well as for-profit and safety net statuses. Notably, profit status and safety net status are separate categories. Profit status is related to organizational tax structure, and safety net centers are approved by the IRS for tax exemptions and are facilities that by legal obligation or mission serve all patients regardless of ability to pay, typically operating on lower margins and higher volumes of low-income minority patients. Our data set includes 131 verified and non-verified burn centers by the American Burn Association and the Burn and Reconstructive Centers of America as of February 2022. We used Fisher's exact test to analyze crude associations between health equity scores and Burn and Reconstructive Center of America status, for-profit status, safety net status, American Burn Association verification status. And for adjusted models, we used an ordinal logistic regression model with the model speculation seen above. The Lown Institute defines our outcome of interest, health equity scores, by three components: community benefit, pay equity, and inclusivity. Community benefit reflects how well hospitals invest in community health and is comprised of three main tenets: charity care spending, which reflects how generously hospitals spend on charity care as a share of total expenses; community investment, determined by how generously hospitals spend on community health as a share of total expenses; and finally, Medicaid revenue, as a share of patient revenue, which is the hospital's commitment to serving patients with Medicaid. Pay equity refers to how well hospital staff are paid compared to executives, more specifically, the ratio of executive compensation to worker wages. And inclusivity is how well hospitals serve people of color, people with lower incomes, and people with lower levels of education. This figure shows the percent of for-profit centers on the vertical axis and the percent of safety net centers on the horizontal axis. Those in green have a higher proportion of safety net centers, those in red have a higher proportion of for-profit centers, and in black an equal proportion. For example, Washington has 100% safety net centers, Idaho has 100% for-profit centers, and Mississippi has an equal proportion of for-profit and safety net centers. This is a similar figure, but by region. Notably, the southern region has a higher proportion of for-profit centers than safety net centers, and the western region has the highest proportion of safety net centers. In this figure, we geomap burn centers by profit status. For-profit centers are shown in red, non-for-profit centers are shown in blue. And here we mapped it by safety net status. Safety nets are shown in blue and non-safety nets are shown in red. This table shows the proportion of burn centers by ABA, BRCA, for-profit, and safety net status. You can see here about half of the centers included in this study are ABA verified at 53.9%. And here we see the breakdown by health equity score. A is the best, D is the worst, with the majority, 41.5%, earning a health equity score of C. And here's also the distribution by region. This table provides the number and percentages of centers receiving health equity scores A through D by ABA, BRCA, for-profit, and safety net status, and their crude associations. Only safety net status was statistically significantly associated with receiving the highest health equity score of A with a p-value of less than 0.001. This table shows ABA verification as a predictor of health equity scores, and there is no association in both the crude and adjusted models. Similarly, there was no association with BRCA status as a predictor of health equity scores in the crude and adjusted models. However, when evaluating for-profit status as a predictor of health equity score, the adjusted model produced an odds ratio of 0.2 with a p-value of 0.04. Holding ABA, BRCA, safety net, status fixed, there is an 80% decrease in the odds of having a health equity score of A when comparing for-profit to non-for-profit centers. When evaluating safety net status as a predictor of health equity scores, we see that in the crude association and when holding ABA, BRCA, and for-profit status fixed in the adjusted model, there's a statistically significant increase in the odds of a score of A when comparing safety net to non-safety net centers, 21.8 times increase in the adjusted model. Our limitations include using a single instrument to quantify health equity and using the health equity of the parent facility as a proxy for the burn center it's housed in. So does for-profit status matter? Our study shows that the odds of earning a high health equity score are decreased if you are a for-profit center. But this is not a discrete linear relationship. Burn center funding is complicated, and facilities must maintain positive finances to remain open and continue providing burn care. Safety net facilities and nonprofit hospitals receive tax exemptions and supplemental funding to balance negative cash flow. Burn centers that are for-profit systems may wish to care for disadvantaged Medicaid patients, but they chose to limit this payer to avoid accumulating deficits, which threaten the existence of the burn center. While profit status and health equity is a complex and multifaceted issue, we need to increase health equity through organized funding structures for hospitals so that they may serve patients regardless of payer status, race, ethnicity, socioeconomic status, and other social determinants of health. Thank you, and I'll take all your burning questions now.
While we wait for questions, you mentioned that you used a single instrument for your health equity measurement. Right. Is there a way to break down this score? Because I can imagine that maybe for this score, there might be some hospitals that are really good at like pay equity, but terrible or less good at community engagement, et cetera. And so maybe, you know, they look very equitable, but it's composed of measures that are not balanced.
That's very true. For example, inclusivity, depending on where the burn center is housed in the country, they may not be able to reach a certain level of minorities to fulfill this health equity score. Also with pay equity, depending on what kind of funding they receive, that might be more disproportionate than others. With the Loan Institute, I think they tried to balance community benefit, pay equity, and inclusivity as the tenets of health equity, just informed by the literature available. But I think that if we widened the scope of tools we use to measure health equity, we can maybe capture it for the diversity of geographical location for other burn centers as well.
Yeah, thank you. This is really interesting work. You know, the disparity you describe, we also, to some degree, see in dialysis centers, right? There actually the outcomes are very different. I'm just curious if you were just to look at this in California, because that's probably easier to just grasp, and you had all the tools available. What would you change tomorrow? How would you go about it?
To increase health equity?
Mm-hmm. Money is not an issue. How would you go about the first step to actually fix that problem you're describing? It's not an easy question. I'm really curious.
It's not an easy question, but I'm eager to try to answer it. Okay. There's no right or right answer. I'm just curious. So immediately my mind jumped to some sort of prevention, education. I think that's something that we always tout as like the most important first step in increasing equity. But I think I want to be very careful about how I answer this, because sometimes we create educational tools or prevention models that actually can increase disparity for people who don't have a baseline. So I think what I would do is really invest with all my money a lot of research into what are the true nitty-gritty determinants of health. For example, I asked every patient on my rotation, who have poor follow-up, why do you have poor follow-up? At Stanford, the #1 answer is pay for parking. So I don't know if, immediately we all jump to race, to sex, to education, but how many of us immediately thought parking is really expensive? So for me, I'd want to make sure that I cover all the bases so that I don't create an intervention that widens disparity.
Yeah, thank you, Nada. I think, fundamentally, if you believe the adage that form follows funding in healthcare, we have huge disparities in how we pay for healthcare in terms of our payer mix. So so long as there's a wide gap between Medicaid and commercial insurance, there's going to be a persistent gap in how we deliver care because hospitals don't like Medicaid or Medi-Cal in this state. And that's a fundamental problem in the system. So we have a last few questions, and just keep in mind we going to start again at 3 o'clock. We're going to have a brief break, but yes, please, just the last few questions here.
Super interesting talk, and it always shocks me. You put up the map. It always shocks me how few burn centers there are in the U.S. But I guess my question related to that is sort of, you have how equitable by this one measure each center is, but there's also the issue of geography and how far away you are from a burn center. This is maybe more of a more basic general question about access to burn care, but have folks looked at places that are sort of deserts of access to burn care? And are there, ultimately it's sort of like state governments and the federal government responsible for ensuring access to this. Are there regulations on the minimum density of burn centers in certain areas?
I think I can help bail out on that one. So there are currently no regulations. As you know, for most of healthcare, if you want to build a hospital and provide a service, there's nothing that stops you from doing that. Maybe in transplant, you have some more regulations about that. But for most of healthcare, it's kind of, if you build it, you hope they'll come. And, 50% of Americans live within 2 hours of a burn center. So, that's a pretty good, and then another like 40% are within 4 hours. So there's just some, folks in parts of like Alaska, for example, or the WAMI in the Pacific Northwest that have longer transit times. But actually the issues bringing up in differences in access and funding status is actually in states where you have a lot of people that are in short distance. Like if you look at Florida, for example, that tends to be the most interesting state to kind of analyze differences because so many different funding mechanisms within a very short distance. All right, thank you very much.